good afternoon to be with you. So why am I here? So one of my roles is I chair the Integrated Care Partnership, which is a partnership of all people in the system to think about how we improve health. So I co-chair that with Councillor Lorna Filker from Southampton City Council. I think for me, if we think about trying to improve health, there's many factors that we need to think about. And one of those is kind of housing and our living conditions and those kind of things. So I think for me, there's something about this is an important topic and underpins a number of things we are doing. And I'm really excited to be chairing this session today. So really, I've been thinking about this and thinking about the integrated care partnership strategy we have, recognising that covers for many of us, most of our patch, recognising that we also need to think about the North East Hampshire bit for those who work in Hampshire. But for me, housing, it thinks about how it shapes our health, where we live, the place we are in is so important to our good health and well-being. And without a good home, many of those things are much more challenging. Thinking about those who may think about your training, the Maslow's hierarchy of needs, we want a safe place to live with good relationships. We need somewhere to be called our home. That's not just about four walls, but actually somewhere where we feel comfortable and safe. And a really safe, affordable home is key for good health and well-being. And we know if you don't have that, that will lead to poorer health. So how do we do that? And we've seen that in a number of settings. And I think for me, there's a few kind of themes we're thinking about, and this is just one of them, but about affordability. We've seen how rent and mortgages have gone up, and that's really challenging for people when we want to think about how we can live and how that impacts on our ability to be healthy. We want to think about the quality of our homes, and we saw that really tragic case of the damp homes causing significant damage and mortality of children. So actually, what is the quality of the home that we live in and support others to live in? And then there's the security of our home. Are we living in stable homes? Do we feel safe at home? One of the roles I have is chairing domestic abuse partnership. Actually, if our homes aren't safe and don't feel safe, we cannot thrive. So many things. And then if we think about homelessness and those who've got vulnerably housed, those are the kind of often when you talk about housing, that's where people go to. And that's really important. And one of the conversations we're having today. So we really need to think about all these issues in the round, but today, as I say, we're focusing on homelessness. So when you look at our integrated care partnership strategies for our area, homelessness is kind of weaved throughout there. There are a number of key themes around mental well-being, social connectedness, trauma-informed, first 1,001 days, and coronary vascular disease, where homelessness will underpin and housing underpins all of that area. And it's really important that we think about how we can support improved homes and the system we're in, so that housing is seen as an underpinning factor for improving health and well-being. And then it also, for those who are kind of closer to the system, there's something called the Core 20+5, which is an inequalities framework the NHS is working to, which we all need to support. And one of those groups of people that we want to improve health for, we've committed to, is about those experiencing vulnerable housing. So we just need to think about those and their families and how we really focus our efforts, which is this seminar is doing for part of it, to improve health and well-being for our populations. And I was just thinking, we've got, as I think as Sharon said, it looks like from the little number I've got, there's 100 people in this room from a wide variety of agencies and partners and walks of life. And that's really, really important, because actually housing isn't one person's agenda, it's everyone's agenda. It affects all of us as we think about those in hospital, those homeless, those struggling with drug and alcohol issues, those trying to get to school when actually their housing is vulnerable. It's really, really challenging. So they impact all of us. How do we all work together on this important issue of housing so that people can work, thrive, learn, and be really cohesive communities to improve the health and well-being of our population. So I think this seminar really sets out a really good, strong place to think about housing, homelessness, and how we're going to tackle that with some really great examples. And I'm really pleased to be sharing the virtual stage with colleagues here. So first of all, I'm going to invite Sian from the ICB, Kaz Whiteman from Two Saints, and Luna, who's on video, to talk about housing and healthcare colleagues and the impact of primary care outreach. So I'll hand over to, I don't know who's speaking first, but I'll start with Sian.
Thank you very much, Simon. Actually, it's Kaz that I'm going to welcome to come in first, and it'll be a bit of a double act between the two of us.
Hi, good afternoon, everyone. Just to give an overview of what we're looking to cover today, the health outcomes for people living without permanent accommodation, barriers to accessing services, health inequalities, outlining the health offer that we have across Fareham and Gosport area, our partnership approach and how it first started. We have some data as well that we're going to go through, admission avoidance and the impact that's had on the NHS, and some top tips for collaboration. So, to get us started, I'd like to introduce you to Luna, a real life story. Just to give a bit of background, Luna was born in South Africa and moved to the UK at the age of 6. She went through 12 different boarding schools in that time, separated from her siblings. Then found herself in addiction from the age of 18, whilst managing school and work, and then became homeless and was actually entrenched rough sleeping for up to 10 years, only accessing services at the start of COVID. I'll let Luna take over and tell her story.
I've been asked to talk about the importance of the nurse at 101, and I was really keen to let you know my story in relation to coming into 101 with no medical information about myself or anything. I got referred to the GP from the nurse, but where I was in active addiction quite badly, and I was a lot skinnier and a lot worse than I look now. There was clearly prejudice, and I felt a lot of shame going there, and I ended up with something quite serious on my lung, a lung condition that he didn't diagnose, and sent me home saying that I was at the tail end of a chest infection and just to go home and rest. Well, when I went back to 101, I was quite embarrassed because I hadn't gone to the doctor in about 5 or 6 years at all. And it was only the nurse the following Thursday or Wednesday that saw me, and as soon as she came to my room, which she was kind enough to do because they don't normally do that, she requested an ambulance. And if she hadn't have been there, no doubt I would have been in a lot worse state. I ended up in the hospital for 21 days. Having come out of the hospital, she was the person that I felt most secure in talking about the struggles that I was having. I'd lost even more weight, and she'd accessed nourishment drinks for me, just general support, talking about my weight, talking about my breathing, loads of encouragement. Not that I'm saying 101 didn't give me encouragement, but on a medical side, I understood the issues, and I understood how my lifestyle was affecting me in reality, not just this emotional stuff that everybody wants to talk about. She was actually telling me the reality of my physical health, and in no judgment, there was no prejudice, she didn't say, oh, you have to stop. She just said, this is the truth, take it or leave it. And that really worked for me because I didn't feel that there was any judgment. She was just looking at it in a sort of almost like a statistical way, in a way, which I understood. And I didn't feel shame talking to her about some of the things, even in relation to some of my friends asking for advice. I could go to her because a lot of us don't want to see or don't feel we can go into these services because we get judged, not just by the nurses or the doctors, but by the other people that are using the facility because they know we're homeless, or they know us on the street, or they've had a negative interaction. On both sides there's anxiety and worry about how we're going to be seen, whereas when she comes into our space, we know we're safe, and we know there's almost like we don't have to pretend. We can just, she knows the real thing. She knows that we're homeless. She knows how it actually is. And I think losing a facility like that, regardless on how many people she sees, it's not the volume, it's the quality of the people that she sees that have made such a difference. I can name 2 or 3 people, and I've asked them if I can use them as examples, like Robbie, who's just walked by. He had an abscess in his lower leg, and he was too embarrassed to go see anyone about it, and he kept asking my advice because I'd had an abscess before, but I couldn't get him antibiotics or get him the help or the dressings. She was kind enough, after some talking from the support at another service that Two Saints offer, to get the nurse to come to see us at Acton. She'd gone out of her way to do that, and she goes over and above. And if she hadn't have done that, I expect that he would have ended up causing a lot more financial losses for the NHS, because he would have ended up in hospital further. So her just coming to do that short consultation meant that he didn't have to call an ambulance, get taken to the hospital. All of these things make a massive impact, because he probably would have ended up in the hospital and discharged himself because he has an addiction to feed. And that's the reality. And he knows, or I know, when I've gone into hospital, when I didn't have a prescription, that actually she helped me get as well. There was so many occasions that I could say, well, the nurse at 101 can help you. And whether they went or not, it was in the back of loads of homeless people's minds that helps there. So it takes a lot for us to sometimes go and seek help, because we have been ostracized, but that doesn't mean that you now stop the help because it hasn't been accessed how you see fit. Or I don't know how to put this without sounding like you have to understand, we pick and choose, but there's a lot of shame involved with who we are. So I just wanted to let you know that it's the value of what she does for each individual that makes a difference. So yeah, thank you very much.
So huge thank you to Luna for sharing her story so openly with us on that video. And I think it's a really powerful message to hear directly from an individual themselves that has been experiencing homelessness, and the benefits of what this collaborative work has done for her and the people that she is aware of. So before we really delve more into explaining about the project and the collaboration and how that's working together to support people experiencing homelessness in our area, I just really wanted to build a bit more upon some of the opening statement that Simon gave us. It really highlighting the reality of the health outcomes for people who are living without a permanent home. And some of these are quite shocking to read. So, for example, the average death of somebody experiencing homelessness is 46 years for men and 42 for women. That's a premature death based on the average population of 35 years, which when I read that, was really stark. Some other, interesting things to be aware of as well is that people sleeping on the streets are 17 times more likely to be victims of violence. Which again is a really scary thought. There's a marked increase in the number of people who have amputations, who are then returning to live on the street with that new disability and being discharged from hospital without a permanent home to go to. Suicide rates are also higher. And to put all of that into context, we're seeing a year-on-year increase in the numbers of people who are living without a permanent home. So more people who are experiencing this stark contrast in their health, in terms of quality of health and life expectancy. So this problem isn't going away, and it's something that we really need to continue to work collaboratively to support individuals in these circumstances to be getting the healthcare that they need to stay well, both mentally and physically. Next slide, please. So just building on that a little bit more, we want to talk about what are some of the barriers for individuals living without a permanent home in receiving the right health support at the right time and in the right place. And as Luna touched upon, some of that is around stigma, and some of that is around, how these individuals feel about accessing healthcare, and what some of the judgments may be from both professionals, but also, as Luna referenced, other people who are accessing those facilities as well. We do know that particularly for those individuals who with a dual diagnosis, particularly around mental health and substance misuse, that could be a really challenging way for them to try and navigate the health system currently, often falling between the gaps, or being passed between services, rather than services working collaboratively to look at that individual holistically in terms of the totality of the needs that they have. As we touched on briefly before as well, we're also seeing significant numbers of individuals who are discharged without a permanent home to go to, so discharged back into homelessness, which can have significant impacts upon both their long-term recovery and the management of long-term conditions once they are back living in that type of circumstance. And all of these types of challenges and barriers are also then having a significant impact on readmission rates for this population back into our acute settings. So, we've got a lot of work to do in terms of working collaboratively to support patients in the community, and really emphasising about that right support at the right time in the right place, and recognising that a lot of the time these individuals end up in A&E or being admitted to hospital because we haven't been able to support them to access the relevant healthcare in the community at the right time. Next slide, please. So just some kind of further information in terms of looking at health inequalities, both in terms of from a general perspective, but also in terms of locally. There is a general perception that it's challenging, or you can't register with a GP if you have a lack of ID. That isn't necessarily the case, but certainly does make it more challenging. Again, around having that lack of address as well to be able to register with your local GP and local health services. As I said before, that falling between several agencies and not recognising the person holistically and coming together. The lack of health advocacy for people needing support with their health, and recognising that it's harder to get out of homelessness than it is to fall into it. Getting support for mental health issues if you're homeless is particularly difficult. And as I keep saying, really recognising the person at the centre of this and wrapping our services around that individual rather than passing them between services. Quite often physical and mental health needs are more complex. And this individual needs, a more multidisciplinary approach to supporting their health needs. And unfortunately, reoffending rates are often higher if people are released from prison back out onto the streets into homelessness, rather than providing them with secure accommodation. So those are some more kind of general overview in terms of health inequalities. And then if we move on to the next slide, please. If we look more specifically at South East Hampshire, which is the locality that ourselves and Two Saints are working on this project, we just really wanted to highlight some of the specific health inequalities that have been identified for our homeless population living in this geographical setting. So there does appear to be more of an inherent issue around drugs and alcohol, and dealing with this in public settings. We also do have an ageing population of substance misusers within the Southeast population, and then obviously the subsequent medical complexities that come along with that. Also recognising with that ageing population, we do have a higher prevalence of dementia, particularly within patients who are struggling with alcohol or mental illness. We are seeing high percentages of people released from prison back into homelessness. So an interesting statistic is around 20 to 30 people a month are being released from the prison in Winchester without accommodation to go into. So they're being released into Hampshire without a permanent accommodation. Obviously, we do have some very rural parts of the county as well. which mean that transport can be a bigger barrier, or access to transport can be a bigger barrier. More intensive support is needed for people to help to maintain their tenancies and to live independently once they're housed. So recognising that just because somebody has been provided with accommodation, the support needs don't end there. And we are seeing a greater need for more direct access into mental health services, as I've said before, not falling between these gaps and then moving further into self-neglect because they're not able to access the support that they need. Thank you. So I'm going to pass over to Kaz now, who's going to talk a little bit more about the project that's been underway between the ICB and Two Saints.
So across Two Saints, we were collecting data regarding serious incidents, and the data was telling us that most incidents were either medically related due to physical or mental health, or clients overdosing on prescribed medication and illegal substances. We see our clients struggle to attend health appointments in clinical environments. This is for a number of reasons, such as fear or judgment, difficulty in meeting appointments, and limited staffing to support with attendance. So we highlighted our concerns at the Hampshire, Isle of Wight, Portsmouth, Southampton Health and Homelessness Strategic Forum, and along with Public Health and the ICB colleagues, we worked closely with them in setting up the pilot service at Fareham, which is based at 101 Gosport Road. In setting up these clinics, we also linked in with colleagues in Portsmouth and Southampton who are already running clinics for the homeless. This was an opportunity for us to really hear about the best practice, what was working well and what wasn't. Our first clinic in partnership with Fareham Health Centre started in October 21, based out of 101 Gosport Road in Fareham. And in the early part of 2022, in light of the success of the Fareham Health Clinic and a strong recognised need for a service like this in Gosport, the ICB pulled partners together in the local neighbourhood, those including the Willow Group and Gosport Borough Council. Willow and Gosport Borough Council, alongside ourselves, we embraced the idea, and from there the big red chair took off. On the receipt of funds from Gosport Borough Council, the necessary equipment adjustments were made. We made visits to the different sites with our partners in health to ensure our space was an appropriate and safe space. And then word soon travelled about the good work that was happening, and Inclusion reached out and offered their services to run alongside our clinics. In May 2022, the Big Red Chair was launched, and on screen you will see a breakdown of the financial costs for these clinics. And if you look at it a bit closer, it's just over £9,100 per year for this valuable service for each clinic. But it is more than just funding. It's a commitment to helping people in health, with a health need, and partnership working. Through our partnership working, it has created further opportunities and introduced other services to meet additional needs. So due to these contacts that we've made through our various discussions in clinics, we're also able to reach out and provide other services like podiatry, hairdressers, dentaid, and numerous others. Next slide, please. So the services provided. We've listed on the screen some of the services we can help with, and a key one through these clinics has been support with GP registration, because of course without the need, with the need of them having to take in documentation that Sam's already referred to, it can prove really difficult for our guys who are rough sleeping or sofa surfing in different places each night. The nurses are able to register patients at that point. So the minute they enter the clinic, they have a health screening, GP check. They're able to register them straight away with the practice without the need for them to have to go in and take documentation. Clients are also encouraged to attend the clinic for a general overall health check when they arrive, or if they're not feeling like it at that particular point because they've just met them, that can happen later on. The other good positive things around the services provided there aren't any strict time slots. So it's totally turn up, and time isn't limited when they're with them either. I think we all know we only get 10-minute slots, and with our client group, it's really important they feel they aren't rushed and listened to. And this really helps when someone's experiencing a mental health problem as well. The nurses aren't mental health experts, but their relaxed approach to time and being open-minded enables our clients to feel better understood and listened to. The outcomes enable the nurses and two Saints staff to effectively work with the mental health professionals once there's a better understanding in the individual issues a client is facing. In addition to the services we've listed on the screen here, two Saints staff will actively go out to our clients in the community or to the local sleeping spots where our sleepers are, and actually bring the guys into clinics, so enabling them to access the clinics without any further barriers of public transport. And the nurses will actually attend and do street outreach with our staff at all hours, and actually offer the healthcare in situ.
Got 2 minutes left, a little 2-minute warning.
Okay. Just some facts and figures here. The screen kind of speaks for itself on that. So with the two clinics that we have running, so 2 in Fareham and 1 in Gosport, the total number of clinics provided in the last 12 months have been 125. Meaning that the number of interventions that the nurses have been able to provide total to 432, so that's 195 for Gosport Big Red Chair and 237 for the clinic in Fareham. Next slide, please. Overriding, you can see there that there's a higher presentation of males in their mid-40s. The youngest clients accessing service at 18, with the oldest client accessing at 71. So yeah, higher concentration in the mid-40s. And interestingly on this one, so the higher presentation was around wound care, which actually was one of the first reasons discussions took place in the first place, with a couple of clients before the clinics suffering with really serious chronic conditions, one of them in stage 4 liver failure, with also ulcerated legs, wasn't able to access clinic very easily. So that is the highest presentation we're seeing in both clinics, both Big Red Chair and the one at 101 Gosport Road. So treatment is provided immediately, prescriptions are raised, dressings are changed, follow-up appointments are made, and in turn preventing sepsis, which in turn then prevents ambulance call-outs, hospital admissions. So we're certainly seeing that wound care is the highest presentation across both, closely followed by mental health. Next slide, please. Dentaid. So Gosport Borough Council actually funded for 8 sessions to run alongside the Big Red Chair. The turnout was absolutely amazing on this. We literally took over the car park out the back of Fulton Road. It was a coordinated approach. We had 8 sessions run across there. And in addition to that, Two Saints also provided ad hoc sessions across Fareham and our other services in Havant. But at the Gosport Clinic specifically, you can see that 34 patients were seen. Now, if you think that whole window for actually seeing clients on the dental bus is literally 3 hours. I mean, these guys really do put all they can into seeing as many clients as possible. And you can see there some of the interventions that took place.
Thanks, Kaz. So I'm just going to talk very briefly around kind of the impact on the wider NHS that this work is having. And what you can see from the screen there is, from the really comprehensive list of services that Kaz has explained to you, ultimately the benefit of this is that holistic approach to the patient. And whilst the individual may come into that clinic with a particular issue in mind, what the staff in those clinics do is really look at that person holistically. They look at what the totality of their needs are. They treat them as an individual, and they go over and above just providing that one intervention specific type of care or treatment. This is about supporting them to manage long-term conditions. This is about proactive healthcare. So really supporting that individual to have a really good understanding of what their health needs are, and how they can best be supported whilst whatever their living situation to remain well. And it's really important to recognise that by providing these services, we are providing intervention at that earlier stage, and therefore hopefully preventing a significant deterioration in that individual's health that then may impact further down the line, requiring that individual to be conveyed to hospital either via an ambulance or themselves attending a ED. So this is about wrapping around the patient in the community, getting the care to them at the right time, but also working in partnership with that patient to ensure that they are getting that healthcare when they need it, and that there is a safe and trusted environment and individuals for them to feel comfortable to approach when they need that healthcare. Next slide, please. And then just to finish up, really, we were asked to consider what we thought would be our top tips for collaboration. And I think it's really important that everybody that comes to the table really believes in what you're trying to achieve and is passionate about achieving the right outcomes for these individuals. It is about thinking outside of those traditional models. It's about being creative. It's about there being no wrong suggestions and feeling confident to bring everything to the table and to have that open discussion. It's about agreeing those guiding principles and asking all partners to sign up to these. So having a really clear set of principles that we're all working towards. It's really important to leave our egos and our badges at the door. It doesn't matter who we are, who we work for, and what our role is. And we're all there for the same reason and to achieve the same positive outcomes for this population. To really focus on outcomes. And that can be really challenging when you've got lots of different organisations with their own agendas, with financial constraints. But ultimately, as long as we're always focusing on the outcomes, the great work will follow. And to recognise the different strengths and perspectives that we all bring. We all see things through a different lens, and we all have something really valuable to bring to the table. And when we come together collectively, the wealth of knowledge and skills that come together in that room really is astounding. And it has been ultimately, I think, the huge success of this project for these individuals. And I'm really pleased that we've been able to achieve such great outcomes for individuals experiencing homelessness in our population. Thank you very much.
Thank you so much, and really good to see. And I think you've really, in that last slide, given those tips for collaboration so important. I think the thing that we don't do very well is actually measure the impact in our health system. So actually, how do we really monitor and understand the longer term outcomes of people who are homeless, so that actually we can show the difference this makes, because it does make a difference, but it's really hard to then articulate that and then show that this investment is making a difference in both patient outcomes, population outcomes, and hospital costs. So I think there's something there, and I don't know who, from the ICB, but I suspect there isn't a finance colleague listening here, because they go, well, that's not, I do finance, not inequality. So how do we really bring our finance colleagues into these conversations so they move that forward? But I think that's really exciting, and thank you to colleagues there. I will move fairly quickly on to Solent NHS Trust because of time. So we have about just under 20 minutes. So I'll hand over to Lisa Kirk and Jodie Pitt from Solent, and I'll give you a 2-minute warning for the end again.
Hi, thank you. It'll be me to start off with, if that's okay. I'm Darren Humphrey. I'm the head of quality professions within Solent at the moment, and I provide some overwatch and support for homeless healthcare. Susan Goddard was hopefully going to be presenting. Unfortunately, she was unable to. I just want to take a brief story, and I'm really pleased to see that one of my esteemed colleagues, Pam Campbell, is in the room with us today, who was instrumental in getting this service set up. Homeless Healthcare Team was set up as a multi-agency project back in '92, follow some of the recommendations out of the Public Health Report in '91, and the difficulties that we've just heard about, and recognising that homeless healthcare people have in accessing our services. Initially, that support was provided from Family Health Services, Southampton South West Hants Health Authority, and Hampshire and Southampton City Council, and the Society of St Dismas, which is now 2 Saints as we know it. Because of the health inequalities, it was decided that the team should be based at a location that was homeless people already using. So our service now sits directly, for those who haven't been there, sits directly adjacent to the day centre. of Two Saints, and their access our services through the day centre into the GP practice. So homeless healthcare is essentially a GP practice in itself. I'm just going to make sure I pop my, I just had a horrible battery warning light come on, so that was a bit concerning. I'm just going to, and if we could, sorry, we're operated next to Two Saints, as I say, and we work very collaboratively with all of our external partners. But originally the team consisted of a practice nurse, a health visitor, community mental health nurse, admin support, and some sessional input from a local GP. Next slide, please. So in '99, the team decided to put together a bid to become a personal medical services, and that was a pilot. Over the preceding years, it was recognised the need for more generic nursing input, locum cover for GPs when they were absent, and addressing some of the problems of duplicate registrations for the out-of-hours cover that had all been raised as priorities for the team to address. This bid was successful, and we attained our PMS status in 2000. This enabled a primary care services to be provided specifically for homeless people in the city to be linked so that patients at Patrick House, Salvation Army, and those presenting to the day centre could have a single GP practice. Registered patients could have access to healthcare out of hours by virtue of having a registered GP. This pretty much addresses a lot of the inequalities that we were discussing and that Sian and Kaz were talking about in that first presentation. So this is a purpose set up with primary care access for our homeless population. And since then, we've had additional nurse practitioners and a practice manager were also recruited. If we could know next slide, please. So who are we then? Well, Homeless Healthcare Team is a specialist GP surgery offering permanent registration of homeless people over the age of 18 and living in Southampton City. For the team, homeless has a very broad meaning, and patients could be sleeping rough, staying with friends, resident on illegal encampments, living in bed and breakfast, hostels and approved premises. Homeless people registering with us as a multidisciplinary team can expect the same level of care and service as they will receive at any GP practice. And I would argue that access to GPs currently through our service is far more accessible than it would be through your standard you and I trying to get a GP appointment at the moment. We have walk-in clinics, we have open offers for that patients to come off the streets, and obviously there's a lot of opportunistic access to patients through the day centre when people are seeing them, and also through our outreach. Next slide, please. So outreach is a really important aspect of what we're doing. The Rough Sleepers initiative is part of what was driving some of that, and outreach has always been an integral part of homeless healthcare. Pam is famously known for riding around on her bike and accessing care and delivering care in a variety of situations. Our team are trying to do that, and Lisa's going to come on, our practice nurse, and talk a little bit about more in detail around that and use some specific cases. But we work alongside colleagues from CGL, which is the drug and alcohol team, our street homeless prevention team, street navigation team, and we support patients to engage with healthcare and register with us as a service to enable them full access to healthcare. Our practice nurse, Lisa, who's on the call today and we'll be talking in a second, she's sets up there's been a ladies' night that's been set up, which is for our sex workers, and that offers them safe and protected time and space to talk about clinical concerns and access to healthcare. Otherwise, they wouldn't be seeking and don't feel always comfortable to come into a practice surrounded by male colleagues. Next slide, please. The important part of this presentation is not me. That was a bit of history and a bit of background. What I really wanted to give the opportunity is Lisa to talk about some of the case examples and that lived experience as a practice nurse operating in homeless healthcare. Over to you, Lisa.
Okay, so these are just some very basic case studies of people. These are the people that we found on outreach. So I go out at 7:30 with the navigator team from the day centre, and we go out to all of the hotspots where people are sleeping and try and encourage them to come back to the day centre to register with the surgery and use any of the facilities there. So we've come across a few interesting ones. Just off of these examples, just on Monday this week, we found a lady who's 67 who has dementia, a history of alcohol problems. She was discharged from hospital. We knew nothing about her at all. She was sleeping on a bench. One of the other homeless people had given her their blankets, and we brought her back to the day centre, got her cleaned up, found out a little bit more about her, contacted her GP surgery to get her some of the support she's needed, and she's been placed temporarily in a hotel. And we're coming across lots of things like this every week, really. There's a new one. This chap was an alcoholic, and we sort of engaged with him. He's reducing his alcohol intake with support from CGL. I think I took him to CGL myself, otherwise he wouldn't have gone. And moving on from this, he is actually now, it's a way down the line now, but he is actually housed and actively looking for work and doing very well off of his alcohol, so really good. And he likes to pop in and just let us know how he's doing now and then, which is fantastic. This is a lady, what do you think? I mean, they're all much the same. If we skip to, I think this is a Polish person that had no funding, and we're coming across quite a lot of these people. They're Polish, they're stuck in Southampton, they've been in trouble with the police, so they can't go home. We had a lot of skin infections travelling around, but we couldn't treat them because they couldn't buy prescriptions, and we sort of managed them as best we could with offering them hippie scrub and wipes and things to try and control the problems with their skin, and it's calmed right down now. We're not having anyone coming through in that way at the moment. Let's go to the next slide. So this is a sex worker who had had several assaults and teeth knocked out in a real poor way. And the only way we actually get to see her is ladies' night. She comes in on a Thursday. It's once a month on a Thursday, and this is how we've managed to do her sexual health testing, smear tests, and just sort of keep on top of her as best we can. She is housed, but then she loses her keys, and so I think she's currently not housed, but it's an ongoing cycle. But because of ladies' night, we are seeing her more than we would. She would never just come into the surgery for an appointment. So by offering that evening once a month, we can engage with people that would otherwise, we would never see them. Next slide. Again, another Polish lady that was really suffering on the streets. She'd been attacked, very violent relationship, and we've managed to get her in Patrick House, and it's been quite some time now. She's still here and she's doing okay. The next one is, typical, lots of chest infections out there. Particularly in the winter, it gets horrendous with chest infections, and they don't engage, they don't come into their appointments, they don't take their antibiotics. We give them antibiotics, they lose them, and they end up really, really very unwell and end up being admitted. But things normally get quite desperate before we get them into hospital. But looking forward to winter, this is the kind of thing we're going to come across an awful lot. And then that's it really, but there's hundreds more. But yeah, that's what
can I just add that I think Lisa's being very probably self-celebratory there. She talks as if that's some of those cases have been very easy, and it's just, this is what we've done. It's not. It's the tireless effort to make that engagement, to connect, that humanistic approach, that holistic approach, to see the individuals in front of you as the people they are, and the individual needs they have. And it's not something that happens overnight. It's not like seeing someone in your GP practice say, look, pop back for your prescription. It takes tireless hours of engagement and selfless commitment to the clinics, to the outreach, and it's incredible. And I think what Lisa has achieved since her time in homeless is very understated by her quick run through that. And I'm mindful that time is, but I'm hopefully the discussions we can generate as a result of these discussions now, will highlight the need for that collaborative approach, that working together, the importance of secure homes and a house, and how we work with our partners to do that. But Lisa, I think was very understated in your efforts there, but I think it's incredible the work you do, and long may you continue. I'll now hand you over to Josie, who's part of our mental health team, which is also embedded within our primary care service. Over to you, Jodie.
We've got
Thank
about
you,
5
Darren.
minutes, that's right, Jodie, but thank you, that'd be great.
That's fine. I will do a whistle-stop tour. So my name's Jodie. I'm a clinical psychologist, and I've been working in homeless healthcare over the past year. One of the things I've noticed that's come up during our conversation so far, you know, Sian highlighted the difficulties of homeless population accessing support for mental health, that kind of dichotomy of, well, you know, people need to sort out their drug and alcohol problems first before we can look at the mental health. And just some ways that the mental health team have been, you know, creatively trying to address some of these. That's what I'm going to talk about with an example. So if you go to the next slide. So it won't be a surprise given what Sian was talking about earlier, and also I thought the Gosport numbers were really interesting, Kaz, about the number of people coming in for mental health, kind of the, you know, second top thing in Gosport after wound care. So 45% of people experiencing homelessness have been diagnosed with a mental health issue, and this rises to 8 out of 10 for people who are sleeping rough. And mental health issues, as we know, are deeply connected to trauma and the adversity that people who are homeless face. If you go to the next slide. So given that trauma may be at the root of why people potentially end up homeless, it is a complicated one, but it's therefore it's further complicated by the fact that people will then often endure further trauma by living on the streets. I think Simon mentioned at the beginning about the hierarchy of needs, and this is a sort of an example of that, but looking at it from a therapeutic point of view, and the importance of people being able to feel safe, be able to develop trusting relationships, experience comfort and co-regulation, have space for empathy, not only perhaps from other people, but also be able to express empathy perhaps for themselves, space for reflection, resilience, resources before you can go anywhere near exploring somebody's trauma. Presents a bit of a dilemma, really. If you go to the next slide, please. Thankfully, there is a psychologist over in the States called Lisa Najovitz who thought about this issue and has done a lot of research over the past 20 years about how you could actually potentially treat these co-occurring conditions that we know that a lot of people who are homeless have a lot of complex trauma, but are using substances as a way to cope. So for the past year within homeless healthcare, I've been running it's coming up to a year now of running a weekly open rolling group for people to come, which addresses both those issues, people that might have had experience of trauma and are using substances as a way to cope. If you go to the next slide. I won't go into detail kind of the programme, but essentially what the topics are aiming to do are to decrease addictive behaviour, reduce suicidality, but to help people think about letting go of dangerous relationships, domestic abuse, addicted friends, gaining some control over extreme symptoms such as dissociation, self-harm, and aggression towards others. You go to the next slide, please. So the group runs, it's just weekly for 2 hours. People can drop in. I'm very kind of flexible on time. So if people are late, as long as the other group members don't find it too disruptive, that's fine. People also obviously, you know, might come, they've had a drink before they've come, that's also fine. It's a very kind of different group to what you might get in formal psychology settings, but the idea is that you start where the person is, and as long as everybody is respectful and not disruptive, then they can kind of come along. Next slide, please. So the year-long pilot, what have we learned? Next slide, please. So I'm currently undertaking an audit. I've got an honorary assistant psychologist who's recently joined the team, who's going to be looking at actually how many sessions we've done over the past year, kind of how many people have come per session, what sessions were perhaps helpful, less helpful. There have been some challenges with collecting data. You know, sadly, participants might suddenly disappear because they've been recalled back to prison. So it has been challenging to kind of capture what has been helpful. But some qualitative kind of success stories. There's one member that came to the group for a good 6 months, and he's currently in rehab. And I had a report that he's doing really well. And there was another chap that used to come who I kind of bumped into by chance, who had stopped coming, and I said, what happened? And he said, oh well, I kind of don't see myself as homeless anymore. I've got this job working for my cousin. I'm in a sort of, I think he's in supported lettings type thing. He didn't have staff support where he lived anymore. And so yeah, again, I think that's a positive outcome. So the learning really is that, we can't be excluding people from psychological interventions because they're presenting difficulties, because there's dual diagnosis, because there's substance misuse. If you go to the next slide, please. So the top tips for working with this client group, this is taken from some recent guidelines that have come out for clinical psychologists, but I think they're just really embedding that trauma-informed approach that Simon talked about in the intro. To kind of recognise that trauma is really highly prevalent for this population, and it might be historic, it might be current, and there might be repeated patterns of trauma going on. And to really work with that pre-contemplation stage. So people will have mixed feelings about stopping substances, and that's okay. It's just starting where the person is. Prioritising the relationship and understanding it takes time to build trust and engagement. So rightly or wrongly, I won't just give people 3 chances to meet with me. I'll give them 6 chances. As long as they're open to the team and seeing somebody. I think it's just trying to meet people where they're at and understand that it might be really difficult for them to form a new relationship. Number 4, so consider the likely trauma histories of the people that you're working with, and that engagement can be a long process, and that trust is likely to be violated multiple times. I actually had a chap who used to come to Seeking Safety who I didn't see for 6 weeks, and then returned, and it turned out he'd kind of fallen out with a prescriber at the local drug and alcohol service, and that had kind of just then made him kind of less trusting of professionals. But he's come back, he's re-engaging, and we're starting again. And finally, that many people who are homeless have lost touch with hope. So it's really important to actively maintain it, which is what the group really has done. This chap that's gone off to rehab has been a real beacon of hope, I think, for other people who come. That's it. Thank you.
And just to summarise, thank you very much to the staff, all the staff at Homeless Healthcare. We've got a team of mental health professionals, primary care, GPs, practice nurses, administrative support, and they're all selfless in how they go about their business, often utilising their own money to fund additional stuff, as we know we all do at time to time, because we haven't quite got the necessary funds to do everything we would like. But thank you so much for taking the time to listen to our staff, and I hope it was useful to give an insight into some of the work that they do.
So useful, and thank you very much. Great to hear all the great work, and I think my kind of initial reflection. So as I'm doing that, please think about questions in the chat or pop your hand up. We've got a few minutes for questions for partners. There's an awful lot of goodwill in these services, and an awful lot of kind of people making those connections. How do we, for me, systematize that? That's the kind of question that we need to think about. That's not for the services, that's for all of us. How do we really show those brilliant stories we've just heard, and then scale those up, knowing that there'll be more people with drug and alcohol problems? I'm trying to change the language there. It's not misuse, it's use, because actually there's many things that cause those people to take drug and alcohol. And how do we really help this be part of the system? We measure things which I could be a bit cheeky. I don't know who's on the call, but that are quite boring. Number of hours you wait in A&E. Is that really helping us improve the health of the population? Let's measure the right things that we've talked about today to really improve the health of the population going forward, so we have an even better population outcomes. My other question is, who's not in this conversation today? And I'm not going to challenge Patrick and Sharon to say, these people have we really got everyone around the table we need to really improve health outcomes for this population? I'll stop there. We've got a few minutes just to have a conversation, so very happy to pick up any questions in the chat. You've got people's details through the presentation, so do make your personal connections outside as well.
Thanks, Simon. If I can just quickly come in, Colin, you go for it, please. You've got your hand up. Come on in.
Hello, my name is Colin McAllister. I work as a senior public health practitioner in the Southampton public health team. I think it's absolutely appropriate, and I'm a firm advocate of the homeless healthcare team, and the Fairman Gosport project sounds absolutely right, and we need to take care to people where they need to access it. My concern is that we also need to have, I think, in the longer term, about why people experiencing homelessness or people with substance use disorders feel uncomfortable going to main healthcare settings as well. I want to ensure that we make those more welcoming at the same time as well. So it's a parallel bit of work, maybe a bit broader, and I hope that's okay.
Yeah, Colin, really good point. And how do we kind of be holistic and think about this for all the people we're seeing, whatever setting? Darren.
I just want to come back on Colin's point. I think it's a really vital aspect of, there's a scale of homelessness, isn't there? There's people who suddenly find themselves without a job and can't pay the rent and find themselves suddenly, and there's people who've been entrenched in that lifestyle for a long time, which have very different needs. And it's how do we prevent people getting down that road, if you like, early enough, and what other initiatives can we have within normal primary care aspect? And because I think primary care is a key area to focus on about how we will pick some of this stuff up. It's the first door, isn't it, for most people? It's only when they become very entrenched and they can't get access to other stuff that they then either don't seek help, as we heard from Luna, or we find themselves having to find purpose-built organisations like homeless healthcare that they can access. And that comes with risks as well, because even though we try and be as accessible as we can be, even where it's positioned in that day centre, for some going through that day centre is quite an intimidating experience if you've never been there. Not all the time. I'm not making a judgment that everyone who's homeless is aggressive or not, but there will be times when people won't want to do that because they're not in the right space. So I do agree. I think it's about that wider shared accountability for homelessness and what we can be doing as a system.
Yeah, good point, Darren. It's kind of, as you say, are we relying on services, or are we thinking about the population needs, and how do we kind of really support those? Hannah.
Thank you. Firstly, just to say thank you so much for the presentations, really insightful. One of my observations is really the biggest gap we experience is in that mental health support provision and the ease of access to services. And I'm just wondering if there's conversations that can be had with the mental health providers to understand their processes so that there's some relief and frustration at trying to access these services, but also ways in which we could widen that access and perhaps have earlier access. A lot of our experience is that we tend to have to push people through quite quickly at crisis point, when actually some slower, longer term treatment would be kinder and less frustrating for the patient. I'm just wondering if there's a way of having those conversations, because I don't think we're alone in our frustration to be able to access those services. And whilst we can offer counselling, which we do offer regularly and quite a lot of it, it doesn't seem quite clinical enough for some of those clients that are needing absolute mental health care.
Yeah, good point, Hannah. I think there's something, a bit of a challenge with mental ill health services, as I like to call them, that what the threshold and the need and what they support is that really meeting the needs of our population, or is that meeting a kind of very medical model clinical need, and how do we kind of really unpick that? Pam, it's a pleasure to have you on the call. So Pam, give your thoughts, please.
Yeah, actually, it was thanks, Hannah. I think that's a very valid point, but it's actually responding to Colin's point again about how mainstream services. I think when we set up 30 odd years ago, we didn't want a parallel service. We wanted those people that could register elsewhere you know, in a place of their choice, because we should all have some degree of choice to be able to do so. And we did a fantastic piece of work with Health Watch probably about 20 years ago around people having the right to register and working with receptionists and managers to make sure that happened. But I stood in my own surgery about a month ago, and the receptionist asked the man in front of me for photo ID and a utility bill, and my heart sank, you know, that we seem to have regressed so far. And Colin, I would say, you know, we did do some fantastic work, but we seem to have just rode back on lots of areas where we probably need to revisit.
Pam, it's a really good point, because actually straight away we're putting barriers up for people for various reasons, and actually what we want to do is open up health services and otherwise, that was the wrong word, people will end up using services that aren't right, so they end up pitching up at A&E because that's the only option, and we don't want that. That's not right for the person, the service, or the outcome. So how do we really think differently? You know, ICB colleagues on table on the room, how do we really turn that around and say, look, why are we asking for, you know, proof of address when these people need our services? Colin.
Sorry to be a pain as well, though. Simon, you're absolutely right. It's about appropriate place at the appropriate time. One of my concerns is the number of people who, after being dosed with naloxone for an opiate overdose, are saying, no, I don't want to go to accident and emergency. Now, there's a multitude of reasons for that. One of those reasons might be that they feel that they're I love our AD, our vulnerable adult support team are amazing, provide brilliant care. None of this is a judgment on them. This is a reflection of the pressure that they are under. People who use drugs, people experiencing homelessness feel uncomfortable in some settings. We need to do our best to make sure that they're welcome to go to the appropriate place at the appropriate time. And sometimes accident emergency is one of the places that they should go. And so we need to make sure that that is that feels okay. Sorry, it's I'd really, choose to find a detail.
Yeah, no, it's a good point. With no other hands, and I reckon that I'm coming to the end of my time. So what I will do is just kind of finish with a kind of few closing remarks, but really want to highlight this is a mini series of Lunch and Learn. I do hope you managed to get lunch while we were learning. Today, it's about kind of connecting together. There on the screen are the next sessions, really focusing on housing, and I think we should do more of these around different topics so that we can really get more people involved in the system, thinking about things that are impacting on our health. So you've got those there. I really want to thank the speakers. It's been really insightful thinking about vulnerable groups, thinking about inequalities, and thinking about some of the system change that we need to happen so that actually we can improve outcomes for vulnerable people. And today we focus on those who are experiencing vulnerable housing and homelessness, and that's really, really important. And actually, maybe this is the start to change the system for other vulnerable people. And how do we do that going forward, recognizing that there's an awful lot of people working to support these people on good partnership and good faith, and how do we really make sure that doesn't fall down, and we need to kind of systematize that work. So I really want to thank everyone for joining in today. We've had a number around, I think a top number, we had 102 people on the call, so that's amazing. So let's think about how we share this thinking. Looks like there's going to be some good evaluation going on, which I think will really help us to embed this in our work and make sure this doesn't just stick in homeless services, but actually kind of going wider. And as Ross says, how do we really show the facts and figures in a way that helps partners and ourselves really understand this issue? We've seen a lot of facts, and I wonder if there's a challenge for Patrick and Sharon to really let's get some facts and figures that we can all understand and share and know what they mean. Recognise we probably need to think about the pound signs and how that works for our system. I think that could be really, really helpful. Sharon, is there anything last from you, or shall we finish there?
No, just a huge thanks from Pat and I, if I may, as I'm speaking, Pat. Don't want to talk for you, but just, you know, it's just so great to have such a fabulous conversation going with so many people today. So thank you so much, Simon. Really appreciate your hosting us and sharing today's first of hopefully many discussions.
Well, thanks very much, everyone. Have a good afternoon, and weekend when you get there in a couple of days, and we'll see you all soon. Thanks very much.